So practically, we have 4 clinical cases, and two of these are dealing with upper extremity injuries, and two with lower extremity injuries. So those injuries are the most common, and you will see many patients with your clinical practice like that. So the first clinical case is about humeral neck fracture. So the patient is falling down on the elbow joint, but the injury occurred in the shoulder joint. So surgical humeral neck is fractured, and that's what you should remember when answering this clinical case. So before you are approaching to the station, on the door you will see instructions. There is no clinical case. There is just instructions, step by step, what should you do. Okay, but when you will enter the station, there is a big screen, and on this screen there is a clinical case. So you can read this clinical case already in the station, and during your answer you can also use this screen. So, of course, you are entering the station, you're greeting examiners, you're asking the patient's permission for examination. Then you approach to a patient and start the examination. So, according to the anamnesis, you ask patient how he fell down. You may get some information from the case data or from the patient. So you should tell the examiner, you should tell the circumstances of injury and the mechanism. So as the force was applied to the elbow joint, but fracture occurred in the humerus neck, that means that the mechanism was indirect. That's what you should tell the examiner. Mechanism of injury is indirect. Then you examine this area and you should determine the location of injury. So you say the examiner, you should tell that the location of injury is in the shoulder joint. Okay, actual humeral neck. Why is it so? Because there is some symptoms that you see here, and there are specific symptoms for a fracture that you should tell the examiner, and general symptoms. So specific symptoms are local crepitation due to fracture, pathological mobility, and the shoulder joint looks not normal. It's deformated. So comparing with the other side, it's deformated. Then you should tell the examiner general symptoms of a fracture. That's actual general symptoms of an injury. So there is a swelling there is local pain when you're trying to palpate your patient. And when patient is trying to move his shoulder joint, also pain is very intensive. So usually the patient don't do that, and he keep his arm with another hand to prevent accidental movement. So next, you should provide some first medical aid. So we start from local analgesics, and on the table you will find a ketanol solution, 1.0 ml. You're taking this ketanol and you are imitating intramuscular injection. So practically for examiner, you tell that we are injecting 1 milliliter of ketanol solution intramuscular. Because patient is in pain. Next step, you should immobilize the joint, and for this purpose you will have the bandage, which you will apply in 2 steps. So first step, you see this is a part which you should put patient's forearm in it and hang it. So these 2 strips goes above shoulders and posteriorly in crossway, and then From anterior part, there are two velcros that you can stick to this part. Second part is transverse part. Then you can wrap patient with it, and it will fix the humerus to the body. After that, when you apply this bandage correctly, you should check the pulse rate. Practically speaking, you're doing this here. I show with my arrow. So distal radius. Why? Because due to injury, the humeral artery may be compressed, other problems. That's what you should check after you apply such a bandage. That's it about this case. So I think we may go through all cases, and then you ask your questions if you have.
Okay, sir.
Yes.
So second case. Second case, that is about wrist injury. So don't be confused that wrist joint is injured, but the fracture is not a fracture of a wrist. We may say that that's a wrist fracture. Many students during previous exams, they told this diagnosis. But practically saying, more correctly is to say which bone is fractured, because wrist joint has 8 bones, small bones, then metacarpal bones, then distal radius, distal ulna. So when you say wrist joint fracture, no one knows what do you mean. That's why this is a fracture of distal radius. This is the most common injury, and that's why we put it as a case for OSCE exam. So again, you are entering the station, introducing yourself, particularly your number, greeting examiners, and ask patient, can we examine you? Then you check screen, and you can see this clinical case information. How the patient was falling down, and please note that patient was falling down on his wrist joint, which was extended, outbended, and the patient landed on his hand. That's why when we are talking about the mechanism of injury, the force was applied to the hand, but fracture occurred in the radius. So the mechanism is again indirect and out unbending mechanism, because we have flexing mechanism and we have extension or unbending mechanism for this location. So next, you should tell the location of injury. So you're examining this area where the patient has pain, and tell that the location of injury is the wrist joint. Next step, you are, after examining the wrist joint, you can palpate this, try to move it. Patient will tell you that it's very painful. But after that, you should tell the main symptoms and additional symptoms for fracture. Again, main symptoms are local deformity, which is called a bayonet deformity or maybe Dine fork-like deformity. There is also crepitation locally and pathological mobility. Additional fracture symptoms are restriction of movement in the wrist joint, local swelling, pain, hematoma in this area. That's what you should tell the examiner. So the next step, what we are doing, we should prescribe additional investigation, and we are prescribing an X-ray, of course. So until this point, if you won't prescribe an X-ray, you won't see the X-ray. So you should tell examiner, you're prescribing an X-ray of the wrist joint in 2 views. And then the examiner will show you the X-ray like that. So looking at this X-ray, you see the distal radius is fractured. You see on lateral view either. it is fractured, and you see that this fragment is not here, it is shifted to the dorsal side. That will help you to make the diagnosis. So that's so-called Colles fracture, which is a fracture of radius in the distal metaepiphysis with a dorsal displacement, okay? Because it is shifted to the dorsal side. Now we have the diagnosis, and next step, you should tell about treatment itself. So the treatment means manual reduction under local anesthesia. So first, we're injecting locally lidocaine solution on the fracture in the fractured side, and after that, you're performing fracture reduction in 3 steps. So first step, it is traction, axial traction along the axis of extremity. Second, you should reduce this displacement. What we are doing, we are flexing the wrist joint on the edge of the table. And then we are doing some ulnar deviation to reduce it correctly. And the third stage is retention. So you're keeping the fracture in the reduced position, and the medical nurse will apply posterior plaster bandage. When the plaster bandage will harden, the plaster bandage will keep these bone fragments and prevent them from displacement. So the reduction was done. Next step is you should recommend patient what to do then. And these recommendations are, so for the first day, as swelling is increasing, you recommend elevated position of the limb. Practically, you're hanging it on the bandage, and when patient is sleeping, the patient can put this forearm on few pillows as high as possible. Second important thing that you should prescribe, ice packs. So local ice application for first 24 hours will reduce the swelling significantly. And you should tell also how long plaster of Paris is applied for. So the plaster of Paris is not circular. This bandage is semicircular. It's posterior cast, and it starts from the metacarpophalangeal joints to the elbow joint. And patient is wearing these for during 4-5 weeks, average period of time. You should also control the position by X-rays. So the same two-viewed X-ray you should perform first day after reduction was done, then day number 7, this period 7 to 10 days, and then in 1 month. When you see the signs of fracture healing, you may remove plaster of Paris, and you can ask patient to move his wrist, to perform physiotherapy, and that's actually what you are doing with your patient. For analgesics, first days when patient is in pain, you may prescribe ketanol in tablets, 10 milligrams, 2, 3, 4 times per day, but that's just for first few days. Later, pain is not so intensive, so patients usually don't take it. Okay, so that's about wrist joint fracture, and let's move to the injury of lower extremity. So this clinical case is already on the street. Yes, so it was a car accident, and you see that patient fall down from the motorcycle, and the force was applied directly to the femur. That's in the case data, and that's you may ask from the patient. So you should tell examiner the circumstances of injury, and that is a road traffic accident, and that the mechanism of injury was direct. Directly, force was applied to femur and fracture of femur occurred. So now you should tell the examiner again general fracture symptoms and specific fracture symptoms. So general symptoms are local hematoma, movements with the hip joint and knee joint, extremely painful, patient can't do that. There is local swelling as well, and when you're trying to palpate this area of femur, it's very painful as well. Specific fracture symptoms, three main symptoms you should tell us: crepitation, pathological mobility at the fracture site, particularly in the middle set of femur, and you can see the deformity. So in the clinical case, it's also mentioned, see that the femur is shortened and it's usually externally rotated and bended in the middle of the thigh. These are main symptoms, specific symptoms for fracture. So next step, according to the clinical case, you should immobilize the femur. That's a very important point. And we have special splints. We use three of them. So one is applied on the posterior part. You see, we shouldn't bend very much under the knee joint, but definitely we should bend here, and the splint will go on the plantar surface of the foot. So this splint is placed posteriorly from the lower back to the psoas. Second splint, short one, you can apply on the inner surface from the groin area to the ankle joint. You may bend it, you may keep it straight, it's not so important. And next splint, longer one, is applied on the lateral surface from axillary region to the ankle joint. Then we have several elastic bandages, and you can bend it below the fracture and then above the fracture to the patient's body. You should not bend all bandages, there are 4 or 5 of them. Just use one to fix here and one to fix here. That's it about the case. Okay. And now move to the last case, which is about ankle joint, also very common injury. That is describing fractures of malleolus, 3 malleolar fractures. So everything is the same. You are entering the station, you are reading instructions, step by step, what should you do? Enter in the station, ask patient's permission for examination, read this case information from the screen, and then again you should determine the mechanism of injury. So look very carefully at the case. You may ask patient, you may read from the screen, and you see that ankle joint. Yes. So patient was walking and twisted the foot. So the foot was twisted, but the pain and crepitation and all other things, problems are in the ankle joint. So the force was applied to foot and injury occurred in another place. That means, again, indirect mechanism, not direct, indirect. So after that, patient was taken to the hospital, and here we examine patient in the hospital. So we should determine where the injury is. It's very easy because where the pain is, the injury is. Also local, you will see hematoma, you will see swelling, you will see, well, I say you will see, but practically speaking, we are taking virtual patients. So this patient won't have fracture, of course. We can't produce a fracture for every case, but you examine the patient and you say that we see hematoma, we see swelling, we see, and when you touch this area, patient will be very in pain. So specific symptoms are crepitation. You should palpate area of medial malleolus, and you should palpate area of lateral malleolus. And here you will feel main symptoms as crepitation, pathological mobility of this malleolus, and you'll find the gross deformity of the foot, as foot usually goes in subluxation. So next step, again, we're making an X-ray, and you should prescribe an X-ray. And after that, your examiner will show you an X-ray on the screen. So the X-ray tells you what? Here we have the distal part of tibia, and this part should be here. So this is a medial malleolus. It is avulsed, fractured, and displaced. So it is displaced from this place to this place. Lateral malleolus is also fractured. Here is the fracture line. And this is displaced fracture, displaced fragment, which should be here. And whole talus with whole foot was displaced to the lateral side. That's why we see here fracture malleolus and subluxation of the foot to the lateral side. That's what we see on AP view. When we check lateral view, we also see so-called the third malleolus, but practically this is posterior edge of tibia. So it is fractured, and you see the talus dome was shifted to the posterior side. So now you should make the diagnosis. 3 malleolar fracture with subluxation of the foot to the lateral side and to the posterior side. After that, you should tell about the treatment. Again, surgical treatment is also possible, but according to this clinical case, we talk about non-surgical treatment. So local anesthesia, local anesthetics are injected in the area of fracture, here and here. And after that, we are performing the reduction, manual reduction, in 3 steps. So traction along the axis of extremity. Then we are correcting this deformity. Practically, we push with hands the calcaneus and the foot to the middle side, and we reduce this displacement and this displacement. And we push it from posterior to anterior side and flex the foot. So we correct posterior displacement. And after that, you should perform retention. So you're keeping this foot in corrected position and waiting until the plaster of Paris bandage will be applied and plaster of Paris will become harder. After that, you're prescribing further treatment plan. So according to this, as plaster of Paris bandage is circular, tubular or circular plaster bandage, it goes from the psoas to the middle set of the thigh, and you should prescribe patient as well elevated position of the limb to prevent swelling, local ice application first 24 hours, and ketanol in tablets, again 10 milligrams, 3-4 times per day, first days. X-rays you should perform after reduction to see if you were successful or not. Next X-ray you should do in 7 days, then in 1 month and 3 months. Usually this fracture requires 3 months to be immobilized. You ask patient to move his fingers during all this period of time. And when you see signs of healing on X-ray in 3 months, then you can remove it and patient start rehabilitation. Movement in the ankle joint, gradual weight bearing, and other types of physiotherapy. That's what is your correct answer on cases related with bone injuries? Okay, students,